Good afternoon and welcome. Thank you for joining us today. My name is Samantha, and I'm the Director of Member and Partner Services for the Florida Association of ACOs. We are super excited for this opportunity to present to you our next installment of our webinar series, Provider Checklist for Selecting the Right ACO Partner. Before we get started, I'd like to share a few quick notes to help you make the most of your webinar experience. For audio, you can currently listen in through your computer speakers, but if you prefer to dial in by the phone, simply click the small arrow up next to the microphone icon in the bottom left corner of your Zoom window and select Switch to Phone Audio. We welcome your questions and thoughts throughout this session. You can submit them at any time by clicking the Q&A icon on your Zoom toolbar. Just type in your question and we'll collect them and address them during our Q&A portion at the end. With that, I'm going to turn our presentation over to Dan Roberts. Dan, take it away.
Amazing. Thank you, Sam. I'll just bring up my screen here.
There it goes.
Just thinking about it. All right. Can we see the screen okay?
Yes.
Amazing. All right, everyone. Hey, so I'm Dan Roberts. I'm Chief Executive Officer for Value Service Management. My career has been at the population health table for most of it. Spent a lot of time launching Medicare Advantage plans, working with IPAs, MSOs, ACOs, clinically integrated networks, and also with population health management vendors. And so certainly have a different perspective on how we can all win at value-based care and acutely understand how complex it can be and how many different breakpoints there are. So really excited for the conversation today. Also have Kishan Srinivas with me from Lenity. Chris, you want to introduce yourself?
Thanks, Dan. This is Kishan Srinivas. I'm the founder of Lenity Health. We're a care coordination company and also Value Service Management's chosen care coordination partner for their ACO.
Amazing. Perfect. Yeah. And so for today's conversation, the next, say, 25, 30 minutes, really want to make sure we get through three things today. One, talk through the understanding and different options that primary care providers have as we are close to that deadline of picking our teams for 2026. Then looking at the three main levers that value service organizations, so VSOs, bring to participating physicians. So how do enablement companies like Value Service Management, like many of the other organizations out there, really help and partner with those that matter most in the ACOs, and that's actually the providers. And then turning over to Kishan to give a bit more of an example of how they partner with Value Service Management and a lot of the work they're doing to help lighten the load for our providers while driving outcomes for our patients. Amazing. All right. So first point, the value-based care tipping point, it's not a matter of if it's coming, but truly when. I think we've all seen that the head is pushed towards getting as many providers in some sort of value-based care model as possible. And while we have seen a few models drop off, we've also seen new models spin up lately. And so I don't think that with the administrative change or any of the other things that are in flux that we've wavered off of the drive towards value. I do think that is something that while the early adopters have been doing for a while, it is going to come for those laggards that haven't done it yet. It is something that we're all going to need to figure out how to balance it with the other considerations that are going on in healthcare today. At the end of the day, a growing spend that is close to 20% of our GDP is not something that can maintain and truly does need to be a net reduction. And so there are absolutely going to be winners and losers as we do continue to work towards value-based care and make sure that some of that unnecessary spend continues to tail off and we reduce that total spend that we're seeing. Now, one thing you'll notice is probably a bit different about this slide than the similar ones that I'm sure we all have seen. Yes, it is certainly a spectrum. We've got fee-for-service on one side and that capitated payment on the far other. But it really is important to remember that underlying word in the middle, and that's balance. It is not necessarily like ripping off a Band-Aid where providers will go from billing fee for service to hopping right into a capitated agreement. What we want to do is make sure that we as enablement groups are truly supporting that journey for providers. And so, yes, there will be shared savings at the end of a performance year, but also understanding how to generate fee for service revenue appropriately in the here and now is equally as important to a lot of these providers. I think we all saw with the Change Healthcare scare when some of that revenue was put on freeze, just how hand to mouth a lot of different PCP offices are. And that stream of continuous revenue is truly important. So thinking about a VSO, so a value service organization, and how they can help enable different providers go into ACO models and participate in value-based care in general. One of the things that we want to make sure we're looking at doing is not putting the work, time, energy, and effort of winning in value-based care all on our providers' shoulders. So just as Kishan's going to get into, making sure that we are resourcing at the office level so the providers are not having to pull from their own MAs, their own nurses, and others to achieve what are uniquely value-based care activities when they have staffed and are operationalizing for their fee-for-service business today. So really trying to wrap around the providers and understanding how they operate in the here and now is so important. So being able to go and partner with the provider and just listen to understand what their workflows are, understand what's working well today and what's not, and then where they are, support with different resources and tools, but not overburdened with things that are not necessary or duplicative. Want to make sure things are as efficient as possible without stepping on the toes of the providers themselves. And one of the things that's certainly a hot topic that we'll get into as well that blends with this is that physician well-being, thinking about the burnout that comes with the limitless tasks and very limited resources, making sure we're focusing on celebrating the wins and making sure that the goals are attainable as we think about what is realistic for value-based care in these ACO models. It's one of the things that is going to be really important when you're looking at different value service organizations, that finding something that shares your values. Every group is not going to be for every provider. There are certainly some models that offer large amounts of money up front and then put providers in agreements for multi-years. And those providers are part of a large conglomerate that has continued success, but it is usually a smaller voice that comes along with that. There are also ways that we can look at these three in front of us, which is more of the aligning on patient outcomes. So thinking about what is truly important and not banging our heads against the wall about a very specific ACO metric, like making sure that a provider certainly meets with us and we want to make sure that they're engaged. But if they're providing good care for their patients, it shouldn't be an exercise of pride to make sure that you're bending a provider to do what the ACO wants. It should much more remain that focus on the two most important players in this space, and that really is the patient and the provider. That second goal here, so shrinking that total cost of care pie while expanding the primary care slice. So that's where we're saying there will absolutely be winners and losers as we get more and more entrenched in value-based care. And as we go upstream, there are services that providers can perform that absolutely lower the total cost of care while generate revenue for themselves. And that absolutely aligns to the mission, vision, and values of an ACO, because we are rewarding the primary care provider for engaging in more preventative services. We're not being reactive. And at the end of the day, it's creating better outcomes for the patient. And that's something we don't lose sight of. That third one there, so the PCP-led ACO, again, some are led by PCPs, some are funded by private equity, some are conglomerates of a lot of different types of groups and entities, or even JVs where the ones have come together. What is really important, though, is to remember that if you are a provider who does want to make sure that you are having your voice heard, ask those questions on the front end. Ask to speak with providers that are participating in that ACO that you're thinking about joining. It is very real to get feedback from existing providers, and a lot of information is lost in those Excel shells of the public use file to show how much a group is made or lost. It really is a value to talk with one of those providers that has been through the partnership over the last year and see, if that pitch deck that everyone sees over the summer really matches the intentions and reality of the following year. So thinking really about leverage and scale while preserving autonomy. So that goes back to making sure that the providers aren't asked to build or pull from their existing resources to do the activities that we know will help succeed in value-based care. And so there are three main areas for this from left to right. So one, that fee-for-service revenue sharing model. One of the things that we do at Value Service Management is try to understand where providers just naturally run out of resources, but there still is an opportunity to improve patient outcomes. Classic example of that is something like chronic care management. We all know that probably 2/3 of our Medicare population is eligible for this. Now, it may not be appropriate for all 2/3 of the population to get there, but understanding which patients have an ability to move the needle through CCM activities and finding vendors or partners that can perform those services and tee up the provider. So important to make sure that those patients that otherwise wouldn't have got those services are now getting it, and the provider or participating PCP is actually receiving incremental revenue for a vendor doing a lot of the heavy lifting of making sure that CCM work is done. Then looking in the middle, so looking at those centralized VBC data and tools, want to make sure that we as an ACO or we as a value service management organization are bringing not just the EHR information that the provider has in front of them, but also the CCLF files, so those Medicare claims. We, for example, also have health information exchanges with Florida, New York, and New Jersey. So anywhere our patients are sitting, want to make sure we're getting that admissions, discharge, and transfer feed. So our providers have the opportunity to do things like transitional care management. If they don't have the signal, that's very difficult to do. Then looking also at lab data, so making sure you've got the national agreements in place with LabCorp and Quest, and getting some of those clinical values that occur outside the four walls of the provider's office, feeding that back, and that way the provider, the ACO, everyone is really getting a true longitudinal view of the patient themselves, not just looking at silos of different data points. And that's when you can really start to understand where there's the right ability to stratify our patients to where wrapping resources around them will move the needle. It's not focusing on high spend patients where there's no real activity other than clinical decision insights that an ACO can really help with. So focusing on where we can provide value. And then on the right, that industry expertise. So really thinking about any provider group that wants to join an ACO, start an ACO, these are not scalable resources. And so understanding which ACOs and which partners have those groups and those leaders that have done this in the past, that understand, yes, what works and also what doesn't, so they can help avoid the pitfalls for providers as they're starting their next year of participating in a ACO agreement. Then really looking here at the possibility of generating fee-for-service revenue. So again, it really is that seesaw of being able to generate revenue in the here and now, but making sure it's done in a way that also has a positive impact on that total cost of care coming down. And so the example that you see here in front of you, really looking at 3 different provider scenarios in an ACO where they have perhaps 50, 100, or 200 members, thinking about what they can get in terms of additional fee-for-service revenue through transitional care management, annual wellness visits, really making sure that they understand when a patient is eligible, getting them scheduled. We find that a lot of providers do a great job of managing the patients that are on their radar, that are regularly coming into the practice, but it's those that are completely off, that haven't perhaps been in for an annual wellness visit in over a year, and we're not getting notifications of when they're coming or leaving the hospital. Being able to introduce fee-for-service revenue opportunities while getting that patient back on track to build a positive relationship with their provider is a really good way for a PCP to generate here and now revenue. And again, just thinking about those different extension models of chronic care management, RPM, that's where we see a lot of our providers leverage our vendors that help expand the reach and cast net of those services they're able to do for their patients that are on their panel outside of their practice. And then there obviously would be a shared savings bonus for the ACOs that are able to achieve it. And so really thinking about an enabler, not just as a vehicle for shared savings, but also for throughout the course of the year, lifting that fee-for-service revenue. And so really seeing the total compensation that they're seeing above and beyond what was a pre-ACO revenue is material for primary care providers. If they have a couple of hundred members, it can start to approach the actual salary that some PCPs are actually making. So this is not insignificant dollars by any means. Perfect. And then the third main area that we recommend looking for is finding an ACO where your voice matters. We all know that providers get into this industry to help people, and usually have a lot of very good ideas. And it's unfortunately been a cautionary tale for some of these larger ACOs, where those good ideas, those pearls, those nuggets are just not floated up to the top. And so ourselves and a few other ACOs are very intentional about making sure that those very real and good ideas bubble up to the top. And so if you look at this triangle here on the left, the way that we like to operate is monthly practice visits. So each month we're getting in front of our providers, understanding for our high utilizer list, for our annual wellness visits, for any kind of patient leads list that we're pushing out, is it working? And if so, great. If not, why not? What can we do? Either additional data to share or additional resources to wrap around that we can then help our practices succeed. That next rung up here is going to be the all office manager and all PCP meeting. So for us, it's very important to understand breakpoints of complex processes. And so actually separating the office managers and the primary care providers, but covering very similar material, gives us unique insights to where things like a transitional care management opportunity can either succeed or fall flat. And talking to the office managers, understanding where they're not getting these notifications or not getting the access to them in a timely manner prevents their ability to do their job. And so get some very meaningful feedback and opportunities that come out of these group sessions. The next rung up here is going to be the subcommittees. So here we have performance, compliance, finance, different major levers of running an ACO, making sure that that is staffed by physicians and that their voice is heard, and that the subcommittees are not rubber stamp committees, right? These are things where real decisions are actually discussed and real suggestions are actually made. The way that we like to operate is making sure that anything that is a material decision for the ACO or any of the ACOs that we serve is discussed at the relevant subcommittee meeting there, and then actually floated up to that board of directors that would ultimately make the vote of how we would move forward as a group. But everything comes from that very first level of the monthly practice visits, so we can understand where there's opportunities or potential issues, route that to our providers, make sure it's on the subcommittee's agenda, and ultimately we're taking an action plan with our board to satisfy a new path forward. These are the things that it is important for providers' voice to be heard, because they know what's going on, and being able to truly take the ideas that we hear on the ground and implement it across the ACO is made all the difference. It's not us as non-clinicians guessing what the providers want. We're hearing it right from their mouths, and we're getting that timely feedback, which has really shown that we can make the most out of the resources that we put in front of our providers. Amazing. All right, Krishna, I'll turn it over to you to give us a story of how Lenity is supporting Sunflower today.
Perfect. No, thanks, Dan. Firstly, for the opportunity to run your care coordination and then also talk about it. I can just move to the next slide. So one of the key things about VSM, as Dan spoke, is they're very, very provider-centric. They're trying to enable the provider that actually have a very strong centrally enforced structure. What we also noticed when we started thinking about care coordination for VSM was most of their physicians or practices were actually making a transition from being a purely fee-for-service practice to kind of getting into the MSSP program and transitioning into value-based care, right? Now, when we talk to practices, physicians, they obviously come to think of themselves as they're already caring for their patients and they're probably going to get paid better for that care. But once they get into the Medicare fee-for-service world is when they realize that there are a bunch of things that they need to do over and above patient care to truly be successful in value-based care, right? Now, there are things around thinking about attribution, kind of trying to grow, your attribution over the course of the year. There are things around focusing on cost of care, like tracking the numbers, trying to see what are the areas where they could do the right things, cut out wastage while still being able to care for their patients effectively. There's this whole thing around quality score, like are they tracking patients? Are they seeing them enough? Are they closing gaps when they visit the clinic? And then obviously there's this entire thing around capturing risk scores correctly so that they're getting paid commensurate with the risk of the population that they're treating or managing as a part of their program. Now, when a practice gets into value-based care, one of the things that we know for a fact is that they get overwhelmed with the amount of work that needs to be done. They'll have to constantly look for data from different sources, build their patient lists. They'll need to do outreaches, and like those outreaches need to be persistent, not one and done. They also need to ensure that when a patient comes into the clinic, they have all the information about the patient to be able to care for them effectively, and also ensure that the documentation closes all the gaps associated with the patient. And obviously, then there is this entire thing around extending care beyond the four walls of the clinic. Now, what we have seen is practices are usually, they want to do this by themselves, but largely because they don't want to disrupt their own workflows and they don't want to create suboptimal experiences for their patients by having multiple people reach out for different reasons. But what they realize over time is it does get overwhelming, and then they kind of have to pick up the battles that they want to fight. So that's where, when we started working with VSM, VSM had this vision that they want us to be operating almost like a concierge for the practice. Like, we have to deeply personalize our offering, make sure that we fit into the provider's workflow versus the providers, like adopting our workflows. And that's kind of where we started our unique high-touch care coordination program. Dan, can I just go to the next slide? So we've been thinking about our care coordination program less as a bunch of people trying to call patients for booking appointments for annual wellness visits or TCM, but we've been actually thinking about it as a no-cost concierge-like experience for providers, their staff, and their members. What we mean here essentially is that we put a lot of effort to try and understand how can we make the whole process of reaching out to us as easy as possible for everybody involved. At the very start of our engagement, we work with the practices. We have some standard SOPs that we take to them. We understand how their workflows are structured, and we ensure that we blend into their workflow. An example for this is one of our practices wants us to review documentation for every patient that's coming in for a visit next day and put all that information into a sticky note in their ECW. While there's another doctor that wants us to use their advanced MD EMR to actually send out messages to key people around things that need to get done. So these are the level of nuances that we kind of run into. Every practice has their workflow, and our job, at least for VSM, is to ensure that we surface the right insights to the provider at the point of care in the form that the provider likes the most. And that's where we make an attempt to understand how do they really like going about this, what are the standard operating process, how much or how little do they want us to do. We then work with their practice POC, their front office, their nurses, to build a working relationship over a period of time so that we are always connected with them. We run our daily patient engagement. We assist with documentation of different kinds. We also constantly do a retrospective review once every month to see if there are any opportunities to improve our alignment and like update our SOPs so that like we are on a path of continuous learning and improvement in some form. For the members, obviously, we don't just call patients for an appointment. We often see that when we are able to give the time, there are conversations with patients that go into 20 minutes and 30 minutes and so on. One of my favorite use cases was this patient who actually spoke to us for 32 minutes. It's a record. And she was talking about how she's been very lonely. She's lost everybody around her. She feels like pretty left out, and she really thanked us for calling her. So what we've been trying to do is to really be there for the patient, center our service around them versus trying to just opportunistically reach out to them for an appointment. So we've been thinking book appointments for them, help them address their social determinants of health. We also, check in virtually on them once in a while to check and see how they're doing, if they're running into any issues, and if they need any kind of like expert help. We also try to make sure that our care coordinator is just available for them. If somebody wants to talk, they can just pick up the call, speak to their care coordinator. They're always dedicated. And what we know is this is one of the big reasons why patients end up in ER, and just having somebody to talk to and reach out to dramatically elevates the burden of them in terms of their concerns about their own health. So we've been thinking about this experience very differently, largely because we want to make sure that we give providers the ability to opt in for all the right reasons. And with our playbook that we've built along with VSM, we've ensured that every provider that we've met to opts into the care coordination service within a 30-minute meeting that we typically kick off our services with, right? Now that's one part of the battle, getting provider buy-in. But the next part is obviously how do we help them make this transition? It has to be in baby steps. You can't have everything go in at the same time. So that's where, Dan, can we go to the next slide? So that's why we built out a very methodical playbook. We typically are working with physicians that have been used to the fee-for-service world. So we say, let's pick annual wellness visit. It drives more immediate fee-for-service revenue opportunity. So they start to see value. We start filling up their blank slots in their calendar. Their patients come in early in the year versus rushing in the last part of the year. they're able to see a measurable impact from a fee-for-service revenue perspective. Purely in terms of their participation in the MSSP program, we are able to help them reduce churn risks. We're able to improve attribution. Sometimes actually their attribution grows on a month-on-month basis. We also are able to use this as an opportunity to close any care and coding gaps in the process. Now, there's one aspect of us making sure that we can help the practice take baby steps. There's another aspect that we're able to demonstrate value immediately and set up a chassis of sorts for long-term success with them. And it also gives us an opportunity to build an alignment in a way that our teams start to work with each other. We are able to kind of get a feel for who likes what kind of communication, and it really helps us to set us up from there on. Once we have the annual wellness visit program working, it takes us about 3 to 4 weeks to optimize that collaboration. We quickly start moving towards additional things. We do TCM. Like we have a team of care coordinators that monitor ADT feeds twice a day. They place a call within 24 hours of a discharge. They're persistent. They call 3-4 times on different days to ensure that they don't lose an opportunity to book an appointment with the patient just because they were not available at a particular point on a particular day. And we ensure that we deliver that entire service of booking the appointment and also ensuring that the physician has the right insights when the patient walks into the clinic within their EMR. So we do the transitional care management. It gives us a great opportunity to start thinking about reducing cost of care as a lever. And then it kind of really gives us the opportunity to start collaborating with different people in the practice and start thinking about other workflows. Now, some of the practices that have started working with us right at the start of the year, they really like the experience. They see that there's very little overheads for them. Everything's in their workflow. And that's where it's easier for us to actually educate to them about what are the other things that you could do. These are things that not everybody does, but if we could kind of like actually enforce a mechanism where we check in on patients virtually once in a while, we remind them on follow-up appointments, we provide certain high-risk, high-cost patients with certain kind of support. It tends to just improve the experience for the patients while also improving your performance and value-based care, right? So that's been our model of operation. Dan, can we go to the next slide? And what we've realized over time is like, it's important for us to provide a concierge-like experience, but it's also important for us to ensure we don't take away too much time or resources of both the doctor and the staff in general. So that's where we've been preaching this mantra in Lenity. We think about a self-sufficient yet connected care coordination model. The way we've developed this is when VSM talks to one of their provider and gets them on a call for 30 minutes, we do the align phase. We pitch to them about what they're expected to go through in the next few months. We tell them about how we can support them. We show them our workflows. We talk them through this, and we typically get a buy-in in about 15 minutes of the call. And then we spend the other 15 minutes to just ensure we talk through all the different items that we want to build an alignment on upfront so that there's less back and forth as we start executing care coordination programs for them. Typically things like getting access to EMR happens to be an Achilles heel for most ACOs, but when we talk to a practice around the value that they're getting, the strict protocols we enforce to ensure that we stay within our lanes, it's easy to get that buy-in upfront. So we have access to everyone's EMR read and write capability. We also get access from them to be able to authorize a call masking feature for us so that when our care coordinators call, they're not calling their patients from a random number. They call them from the practice's number. That's been great from a conversion standpoint. Then we obviously think through a little bit about what are the protocols to follow when we're booking appointments? Does the physician like appointments on a few dedicated dates or a few dedicated slots every day? Or like, are they fairly open with us booking anytime when there's an open slot? So we go through that and escalation mechanisms and other standard processes so that we really know how to personalize our program. Now, once we roll off the align phase, we take about a week to get our program started. That's when we do daily patient engagement, like we do outreach activities, we review next day appointments, we perform documentations, we do virtual check-ins, we escalate anything that might actually come into that a practice might need to know when we engage with one of their patients and so on. And on a weekly basis, we ensure that we spend sufficient time sending out focus patient lists that we're going to outreach to. We also send out like potential observations that we have in terms of areas where the practice could actually do one better to be able to like realize the value of all the effort that they're putting and so on. And on a monthly basis, we ensure that we have a retrospective review. We measure everything that we do. So practices are able to see what's the extent of movement they've been able to make this month, how are they trending, and so on. So that's been one of the big reasons why we are kind of trending towards hitting an annual wellness visit rate of about 60%, even before VSM enters Q4. So Q4 is the place where we can easily do another 20-25%. So we are able to considerably exceed benchmarks of annual wellness visits with providers who are only just getting started in their value-based care journey, right? So that's a brief presentation. We wanted to share some of the best practices that we've uncovered, obviously with great partners like VSM, and we have tried to really go deep in determining if care coordination bandwidth wasn't a problem, how could we reimagine it in such a way that it's centered around the physicians, it delivers a lot of value for them and their members, which is the ultimate goal of what we want to deliver with value-based care. Dan, back to you.
Amazing. Kishan, thank you for highlighting a lot of the hard work that you're doing. And like I say, it is real and it works. Having worked at other ACOs, I know a lot of times where we've taken lists out and we've asked providers, their first reaction has always been, oh no, this is more work for us. And now it's very much okay, how is Lenity going to operationalize this for us? And so it really does break down that barrier where there might not be a resource to do it otherwise. But appreciate everyone's time today. Like I say, wanted to run through what we're seeing as the most important things as you're finalizing those selections for the ACO partner, knowing that really the end of this month is when everyone is making that decision for 2026. Happy to address any questions that anyone's had along the way.
Yes, thanks, Dan. We know the deadline is fast approaching, so this was valuable information. Looks like I do have a question here. What is the main driver that influences ACO selection for a provider?
Yeah, so good question. And it's anecdotal. I would say that based off of this year, what I've really seen is a bounce back to providers wanting to be a bigger fish in a smaller pond, or at least have their voice heard, making sure that there aren't activities that are being pushed down to the practice level that aren't bought in from the providers. So really making sure it is that partnership and not a one-way conversation.
That's great. How important is it for a long-term care provider to be in an ACO with like providers?
Yeah, so that's a really good question, and we didn't get into the long-term care split, but for value service management, it's critical. What we see right now is, yes, there are different benchmarks for long-term care providers compared to those more community-based primary care docs. But there are also a lot of different operations and a lot of different needs that the patients have. There's the consideration that many times long-term care providers are operating in skilled nursing facilities or assisted living facilities they do not own. And so the access to EHR and some of that clinical data is more difficult to get. So having a partner that understands that incentivizing the facilities is going to be equally as important to succeeding here is important. And then really making sure the right resources are wrapped around, if you're thinking that institutionalized patient base, there are things that are going to be more relevant. Around things like palliative care and hospice, and making sure that there's an appropriate level of enrollment there. And we're not seeing patients only enroll in hospice in the last 10 days of life because they're not getting the benefit of the service. So really making sure that you've, as a long-term care provider, aligned with an ACO that understands the nuances of all of that.
That's great. And then the last question I did have for you today, Dan, and this is a good one, is after shared savings are generated, how does VSM share them with their participating providers?
Yeah, absolutely. And so this is an interesting question, right? Because there are many different flavors of how ACOs will share their shared savings along with the provider group. We're very much of the mind that rising tide should lift all boats. And so if the ACO is making money through shared savings, that those providers that are participating, whether they individually at the tax ID level generated shared savings or not, should be rewarded. And so what we're able to do is, through our partnerships with groups like Lenity, is wrap resources around providers that are perhaps not achieving shared savings to keep that performance high. And then we really do distribute based off of yes, attribution, yes, some stewardship, so attending meetings and making sure that we're hearing any kind of issues that the providers are having, and then aligning on certain quality gaps and things that we're all saying are important for success behind the ACO. But for us, it is, like I say, it is important to make sure that if the ACO succeeds, that all providers get a portion of that, because it is hard work, and in small panel sizes, there are a lot of times that providers couldn't have done things differently to individually end up right side up or wrong side for their shared savings, and being able to reward them for following it and knowing that it is a process and it's a multi-year agreement, and that as we grow, these fluctuations smooth out. So really rewarding the providers for sticking it in the long run is where we like to focus, as well as providing equity for our docs that join year one. We really do see them as partners through and through.
That's great to hear, Dan. I appreciate you presenting on this, especially with the deadline fast approaching. I know this is valuable information and insight. So thank you again for bringing that expertise to us today, and thank you to everyone that has joined us in this session. Just as a follow-up, we'll be sending an email that does include Dan's contact information. Should you have any additional questions, you can reach out to him directly. And if for some reason, you can always reach out to me and I can connect you with Dan as well. We do recommend sharing this recording with your colleagues or peers or anyone who may find it valuable. And we appreciate your participation and encourage you to keep an eye out for upcoming announcements and other webinars in our series. We hope you all have a great day and take care, and good luck to everybody approaching the deadline.
Awesome. Thank you, Sam. Thank you, Kishan. Bye.